My name is George Ntaios, and I serve as a professor of internal medicine at the Aristoteles University of Thessaloniki in Greece at the Achiapa University Hospital. Atherosclerosis is a procedure which takes for decades until at some point it becomes clinically evident with complications. Now, depending on the way that we live, on our lifestyle and on our genes, perhaps sometimes it may be a bit accelerated. So today I discussed about those two conditions which really accelerate atherosclerosis and brings its complications much earlier. So the first disease that I talked about was lipoprotein A. Lipoprotein A is a molecule which is very similar to LDL cholesterol. It has the same structure plus an additional molecule which is a chain of some molecules which are called kringles. So lipoprotein A is actually LDL cholesterol plus kringles. Now, the LDL part of the lipoprotein A is responsible for its atherosclerotic properties, but the kringle part is responsible for its prothrombotic properties, and also it's also responsible for its inflammatory properties. So actually it's an LDL cholesterol which doesn't have only atherosclerotic properties but also has prothrombotic properties and pro-inflammatory properties. So it seems perhaps to be even more dangerous than LDL cholesterol. So lipoprotein A is really highly prevalent. It can be found in about 20% of the overall population. So 1 out of 5 persons have high levels of lipoprotein A, which means that they have higher risk for stroke and other prothrombotic conditions. Now, lipoprotein A for the moment doesn't have any treatment. We cannot treat high levels of lipoprotein A, but currently there are trials which assess molecules which are under development to treat high levels of lipoprotein A. For the moment, the available evidence shows that these molecules can decrease the levels of lipoprotein A for more than 50%, which is really an excellent percentage. And nowadays, there are ongoing trials which look at the clinical endpoints of lowering lipoprotein A. These trials are expected to be completed in 2 or 3 years from now. So if these trials turn out to be positive, that means that we will have a very strong tool to reduce the atherosclerotic risk in patients who have high lipoprotein A levels. The second disease that I talked about is familial hypercholesterolemia. So it is this genetic disease where somebody has 1 or 2 genes which lead to higher levels of cholesterol. Now, there are 3 main genes which can cause high levels of LDL cholesterol, which are mutations in the LDL receptors, the second gene are mutations in the ApoB part of the LDL cholesterol, and the third gene, it's an allele which causes a gain of function of the PCSK9 molecule. So familial hypercholesterolemia can be homozygous and heterozygous. Heterozygous is not that rare. It can be found in about 1 every 5,000 births. On the other hand, homozygous hypercholesterolemia is really rare. It can be found in about 1 every 1 million population. Now, the heterozygous hypercholesterolemia is associated with really high LDL levels. The homozygous hypercholesterolemia is associated with even higher LDL levels. You can find LDL levels up to 800, up to 1,000 milligrams per deciliter. So, as a result, persons who have homozygous familial hypercholesterolemia may have strokes even from their childhood. On the contrary, people with heterozygous FH have strokes at about their 30s or at about their 40s. So what we need to do with those patients for heterozygous familial hypercholesterolemia, we have currently very good drugs which can lower LDL, like statins, like ezetimibe, and like PCSK9 inhibitors, like evolocumab and alirocumab and inclisiran. With regard to patients with homozygous FH, since a few years now, we have a new molecule. This is angiopoietin-like molecule. It's called evinacumab, which reduces by approximately half the levels of LDL cholesterol, and without this reduction, these patients might have a stroke very young in their life. So it's very crucial to find those patients on time and reduce their LDL levels.